Welcome to another episode of the Aligned and Elevated podcast. I'm your host, Dr. Allison Feldt, owner of Body Motion Physical Therapy, owner of AF Wellness Coaching, and mom of 3. So I'm super excited today because today we are going to focus on endometriosis. And we're going to talk a little bit about endo, we're going to talk about women's health, we're going to talk about sports performance and training, especially related to endometriosis. So we have a lot on the docket today, so we're going to jump in. And I have with me today one of our one and only and very first rehab technician, and her name is Bella Perez. She is a Division I college athlete. She rows, and she is going to tell us all about herself, whatever she's willing to share, and then she's going to ask me questions. So she's been super, she's just a great learner. She is the epitome of someone that we hire here at Body Motion, just asking amazing question after amazing question, trying to understand the human body, trying to understand women's health, and integrating that into her personal life, but also into what she wants to do for her future. And so I've really valued these questions that she has brought on the table, and I just felt that they were so good that we should do them on the podcast. So welcome to the podcast, Bella Perez. Thanks for being here.
Thank you so much for having me. I'm so excited to be here.
Yes. Tell everyone where you row.
Yeah, I row for UCLA. I'm having an amazing time there. I was fortunate enough to be able to walk on, and I'm going into my sophomore year there. Lovely. So I'm super excited for that.
Great. So why don't you tell us a little bit about your journey with endometriosis and why, if you don't mind just sharing your journey. Totally. I think it's super relatable. It's what a lot of people go through. Mm-hmm. So give us your story.
Yeah, so I first started having symptoms when I was 11 with my first period. And it was just the craziest, most painful thing ever. And I had never had a period before, so I thought this was absolutely normal. And when I went to my pediatrician, this was also not really recognized as abnormal. And so I continued to have this for many, many years. And I was very hesitant to try anything other than Advil or kind of the normal precautions that people take. And so as I was kind of going through this, I also became very invested in rowing. I was probably practicing and training like 20 hours a week. And what I had noticed is that I had these intense menstrual-like cramps when I was working out. And that was actually my main symptom going forward that I would present to with OBGYNs was I'm having menstrual cramps when I'm exercising. And what happened with that is a lot of people didn't automatically go to endometriosis. And what was interesting, though, is they also didn't go to pelvic floor dysfunction, which is kind of working here a little bit. Those are the two main things that I think you would kind of assume. So I actually wound up being referred to a cardiologist. I have no issue of heart problems, thankfully. And the conclusion was essentially that I was just like having some type of like stress response in my heart and like some like adrenaline or something. So I was totally fine in my heart and all of that stuff. And then I was referred to therapy, and it was actually not, thankfully, a mental health concern. It was actually just a physical problem. And so when I was 18, I was fortunate enough to really get kind of aggressive in pursuing surgery. And I had decided that this is what I wanted to do. I decided to not pursue being recruited into rowing because I felt like I couldn't guarantee the coaches of the teams that I was going to be able to row in college. And so I went to like 4 different surgeons. I found my surgeon, and I had an amazing surgery and recovery experience, and I was later able to walk on to UCLA after that.
Perfect. And
I've had an amazing year. I haven't missed a practice. I've been like relatively like low symptoms, and just such a huge change from the year prior. Like anytime I was working out having crazy cramps, like
so
absolutely.
I'm going to back up your story a little bit. How did you figure out that you needed surgery? Like totally. At that point, were you already considering that you had endometriosis, because this usually takes people a minimum of 10 years to get diagnosed.
Totally.
Endometriosis diagnosis gold standard, as far as I know, still is laparoscopic surgery to actually be able to tell. I know some imaging can say, oh, there's possible endoadhesions here. And I'm just gonna back up really quick. Endometriosis is described as having endothelial-like cells outside of the uterus itself. And this could be in your brain, this could be on your heart, it could be in your diaphragm, your lungs, or really commonly in the endopelvic fascia, which is the fascia that covers the bladder, covers the uterus, covers the fallopian tubes and the ovaries. And so it's very common for people with symptomatic endometriosis. There are people that have no symptoms and don't realize that they have endometriosis until they go on a long infertility journey. But when you have symptoms of endometriosis, very commonly you can have painful intercourse, you can have painful menstruation, you can have heavy bleeds and heavy cramping that is debilitating, and you can also have pain after exercise, and generally you can have that cramping with or without exercise.
Totally.
Everyone has a different degree of endometriosis. Endometriosis could also just be this chronic hip pain that won't go away. And so there's a lot of different ways that endometriosis shows up. And what people are finding now is that it is much more common in women to have endometriosis than it ever was before. Whether that's our current environment or whether that is just that we didn't have a diagnosis for it, or a way to diagnose this more clearly, is up for debate. But as far as we're concerned, these are just common symptoms that people will experience with endometriosis. And one form of way to manage the endometriosis is to remove those endothelial-like cells that create adhesions, is to remove them laparoscopically. However, when you remove them laparoscopically, you actually end up with scar tissue that is left behind. And so it's really important to manage that scar tissue. Now, I just want to ask you a question here. So, on your journey, let's go back to that question. Yes or no, did you suspect you had endometriosis?
Yeah, so with my main symptom being this crazy cramping with exercise, it was really a huge risk to pursue surgery. And I think that's the most common thing that I hear when I'm talking to other young women who are pursuing surgery is, what if I'm wrong? And there is a lot of messaging when you go to doctors, when you know realistically this affects about 10% of people. This affects most people who are missing school. When you know that there's not really any other plausible explanation for this, it's a huge risk on yourself, or kind of betting on yourself and trusting yourself to choose surgery. So I was really unsure if I had endo, because there's a severe lack of research into my specific symptoms. Women's health and women in sports in particular is the perfect collision of under-research. And so really what I was just looking up was other women's experiences. I think there's one other athlete or rugby player who's talked about this experience of having cramps during menstruation. I really just took a hold of this, and I was like, I think this could be what's happening with me. So instead of having this what medicine should be is doctors saying, hey, this is an incredibly common thing. This makes sense given your family background, your family history. Instead, you just have kind of word of mouth. So I think it first popped into my head with the whole painful periods, which wasn't even my main concern. Totally.
So I'm going to just pause real quick for everybody to realize the strength and the power that women have when they're living in alignment, name of the podcast, with themselves, is the trust and the magic of having that intuition. And that's not validated, unfortunately. And you can go to the doctors and they're going to tell you the risk. They're going to, give you the rundown. And you had to be so in touch with yourself and aligned and go based off intuition. Research doesn't give that to us, and research actually never will give that to us. And that's where being consciously aware you're and like pursuing growth like you do, and being just living life in line with your intuition, which is really, really hard to do, and you're so young, and it's so impressive to see that right now in you. I just hope that you can take that as a badge of honor, because it is, for every single woman listening to this, I think that is one thing that is the hardest thing to do, is to execute on your intuition. Constantly, always, and forever. And we can give you as many examples of different case studies. We can talk about different health ailments and different experience that other people are having, but unless you're fully, embodied in yourself, which is really hard, especially when other providers are telling you it's a mental health problem, right? Or this is just in your mind. This is your heart problem. It's like you had to go against people who have years and years and years of medical training and authority to be like, no, I actually think my body, it's this. That is very, very challenging, and I think that is something that speaks eons to who you are, and it's also just a great example of don't give up, right? It's like keep pursuing it until you find a solution.
Absolutely.
So cheers to you on that.
Thank you.
I also want to know, did you try pelvic floor physical therapy before surgery?
Yes, I actually did.
Okay.
It was actually a really eye-opening experience for me, and really was the reason I decided to go forward with surgery.
Okay.
Absolutely. So I had been very hesitant. I was seeing a doctor, and she was pretty dismissive, and the one thing that she really gave me was Lupron, which is a very, it's used to basically put you in menopause, which is absolutely not what I wanted as an athlete, as someone who's like physically growing. My bones are still growing. It would put me at permanent risk of osteoporosis, just kind of a crazy option, and it's one of the few treatments that are specialized for endometriosis, but because of how aggressive it was and of how young I was and not having a previous surgery. So that was one option I was given. Then I was given just like mental health, like kind of work through it that way. Lupron's also used to treat breast cancer. So that's kind of the intensity of what we're talking about here. It's just definitely is the right choice for a lot of people, but maybe not when it wasn't the right choice for me.
Yeah. I actually haven't heard of Lupron, so you're bringing that to my attention, and that's so interesting. But in this day and age, everyone's just given a pill. But again, this speaks to obviously that didn't feel aligned in your body, and you didn't want to go that route. So that's impressive that you didn't. And so then the next option.
And then the third option was pelvic floor physical therapy.
Okay.
And I think that was really to kind of get me to stop seeing her and bothering her, if I'm being honest, because I was having pain to the point of like passing out and vomiting and just like craziness. And so I would obviously be bothering this woman a lot. I'd be making an appointment because I wasn't getting better with take 4 Advil, take 2 Tylenol. Have you tried like a heating pack? Like this was not helping. And so I would just keep on I saw her maybe 4 times within a year. And she just kind of was done with me, and she's like, how about you try pelvic floor physical therapy? And I actually never did see her again after that, because I went to the pelvic floor physical therapist, and she said, I think you have endometriosis, I think you need surgery. And I learned a lot of really helpful tips from her in managing kind of a lot of my symptoms. And it was just amazing to have someone finally say, like, I believe you, I see you. It was the most detailed survey that I've ever gotten. We just sat and talked about my life, my athletics, my symptoms, my entire history with all of this, how I've been dismissed for like an hour and a half. Just someone listened to me, and that really gave me the confidence in myself that I could then pursue surgery.
That's amazing.
Absolutely. And it was just amazing to have someone listen to me in that way, and that really did spark my personal interest in physical therapy. I kind of saw the medical rushed doctor side of that, and then I saw this physical therapy sitting with the patient, taking information, just listening, and then helping. And it's not like surgery or anything that kind of gets all this glory, I think, in mainstream media, this idea of like, this pill will fix you, this surgery will fix you, but it's just, this is some abdominal exercises you can do, this is some foods you can try, this is just small little steps, nothing crazy, but it's more of a team effort towards healing. And also just being empowered to pursue surgery. That was the right decision, but definitely that worked together. Yeah, absolutely.
Oh my gosh, that is a beautiful story. I literally want to shed tears. So thank you for sharing.
Yeah, of course.
Did you do hands-on treatments too?
I did.
Okay.
Yeah, totally.
Yeah, so I'm going to just like segue a little bit. When we see clients with endometriosis or who think they have endometriosis, we always, for that, like we're treating the symptoms and of course we want to get to the root cause. Some people don't want to go with endometriosis surgery and or they've had the surgery and haven't gotten better. These are two very common things.
Yes.
And so there's a couple things to think about here. So I'm going to put an asterisk on this. You can have the surgery and it takes a very skilled surgeon to find endometriosis. I've seen surgeries of endometriosis from some of the top experts in this area, and I mean just footage just from their surgeries that they've shared on specialized trainings. And it's very, very easy to miss certain endo adhesions. So you will have people that have, sure, they had endo surgery, they had it resected, but they're still extremely symptomatic. And so that's one way. You can also have people who don't want to go the surgery route and they're trying to do everything they can to do it because maybe they want a baby right now, right here. They don't want to have to go through getting another step of a surgery. And so these are different things. So a little bit about how we intervene in that process and how pelvic floor physical therapy can absolutely be just a complete and utter game changer in order to manage endometrial symptoms. Number one is that we can really help the endopelvic fascia move, meaning that if you have embedded adhesions, not only can we work to hopefully disintegrate some of those adhesions, we don't have research that we can do that with our manual hands, but what we can feel is that we can really help adhesions move so much better within the tissue, which can help people manage symptoms. So we have a lot of clients who have a history of endometriosis or they have previous endo surgeries where they're just coming in once a month for maintenance to get their tissues moving, to get the blood flow to those tissues so that they move. And when tissues are moving around those adhesions, a lot less painful. You don't have that tension, you don't have the tightness. One reason that you probably got a lot of cramping post-exercise is because of how fit you are and how tight your muscles are, and then you're working those muscles that have adhesions in them, and they're not being able to relax. The muscles can't relax, so then they're just squeezing because they're in pain more and more and more, and so you're not getting that relaxation of the muscle, and it's extremely painful. And so from a conservative standpoint, what we would do is we would help those muscles relax. We would get those adhesions moving so they could help the muscles contract. And when I say muscles, I'm talking uterus, I'm talking also the deep core muscles and the pelvic floor. So I'm not just talking about the muscles we can control. I'm talking about muscles that we also can't control. And we should also say that even the smooth muscle of the colon is really important to get moving because if you have adhesions around the colon, and you just need your colon moving really, really well when you have endometriosis because any constipation, diarrhea can really wreak havoc on your endometrial symptoms. So these are just things to consider. So this is what we would do from a preventative standpoint to help prevent surgery. And then this is also what we would do to help manage people that maybe surgery wasn't fully the answer and they're not ready to go for another surgeon to go find more adhesions. And or there's some people that just continue to lay down new endometrial cells and this is what keeps them going between the surgeries. So there's a huge gamut of how we address and manage this. And the other thing that has been super fun from like my perspective, I say fun, but is because when you see changes as a provider, it is so fun. When you can change the quality of someone's life, that is epic, right? Like it's just, there's no words. There's absolutely no words. And so the other thing we use is our regenerative tools, and that's why we hired Bella, really. She helps us carry out regeneration medicine here. And we use our shockwave machine, our radial pressure shockwave machine, and we use our EMTT to help with endometriosis as well. And so when we are doing shockwave, the radio pressure shockwave around endometrial adhesions, around the uterus, around the fallopian tubes, in the lower abdominal and abdominal area, we're freeing up adhesions. And now, are we disintegrating adhesions? We'll never know. I hope in my dreams that we're disintegrating tissue, but if we were to do a research study, you can't even research this stuff because you would need a surgery beforehand to identify the lesion, which then you would just take it out. And so you would never leave it there, and then you would have to close it up. Then you left more scar tissue down, shockwave it a bunch to see if it went away, and then reopen it up. And then that creates more scar tissue. So you would just never do that on any human subject or really animal subject, either. That just wouldn't be, that would never be ethical. And so that just couldn't happen. But I have a secret vision and hope when I'm treating clients that we are melting away their endometrial adhesions. But again, it's really what we're doing is we're melting away their symptoms. We are helping the fascia release those endometrial adhesions so that it's not gripping so much, causing those symptoms and causing the pain responses to those symptoms and causing increased tone and tightness in those muscles. So that's what we're doing. And from a pelvic floor perspective, there is many times, I used to never be able to say this confidently, just so you know, there's many times where I will feel nuggets in the pelvic floor. They'll feel like little rocks, or I'll feel adhesions in the pelvic floor, and I'm just like, okay, it's an adhesion. But what I'm learning now, and after reviewing a lot of these a lot of the surgeries that we've been able to see, it's like, no, what I'm feeling is endometrial adhesions embedded within the pelvic floor. And so when you can really feel that, and yeah, you might not get it to melt away, but you can get it to really start to move, you really change the symptoms. So I didn't mean to take over, but I just wanted to give kind of a basis for how we manage endometriosis in the clinic, and really how we can improve symptoms holistically without having to jump to surgery and or just maintain it between surgeries.
Absolutely.
Because you will have people that cannot function until their next endometriosis surgery, endometrial resection surgery. So thanks for letting me share that.
Of course.
Do you want to, you have a whole list of questions we haven't even gotten to, but
of course.
Why don't we dive into your questions?
Absolutely.
Okay.
So I think we hit on a lot of them already. I think my main question was kind of tying back to what steps can someone do. So I think that ties into when you come into physical therapy, what does that look like from a provider point of view? What is walk me through your thought process of what kind of steps are you going to take?
Yeah. So just how you mentioned you had an intense intake, that is so important.
Absolutely.
Finding out that you had these painful menstruations, and sometimes they're so heavy. I don't know if you had heavy bleeds, but a lot of people have heavy bleeds when they have heavy cramping. Because if you have adhesions within the uterus or around the uterus or anywhere in the endopelvic fascia, once a month when the prostaglandins release to go slough the lining of the uterus, if you have tension around that uterus in the endopelvic fascia from adhesions, from previous scar tissue, what happens is the uterus has to work extra hard to squeeze and slough that lining every single month because it's working against the resistance that is coming from the adhesions. Does that make sense?
Yes.
Okay, so if we have to work against that adhesion, we are gonna just contract and work. So you are sloughing so much of your lining. So this is where a ton of heavy menstruation to us, for us, we think, okay, the uterus needs to get moving. We need to move the endopelvic fascia. We need to move everything connected to the uterus and to any of the reproductive organs. So we can free it up so it can move and ebb and flow. Some people get pain with ovulation. And so if there is tightness, around the endopelvic fascia where the ovary is, and the ovary is trying to release every month, and you feel that as discomfort, there's tension or scar tissue pulling on that, and we need to address that. In order for a woman to have a healthy cycle, we need all of this to be pain-free. And one thing that I think needs to be said is that no period should ever be painful.
Absolutely.
And so a painful period is a red flag. And I'm going to say a really bold statement. Most people might not agree with this. The first step to treat a super painful period or any menstrual cramping should not be birth control.
Mm-hmm.
Because then we are just covering up the symptom.
Yeah.
And so sure, we might mess with the hormones a little bit to decrease the prostaglandins that are released that cause the cramping. But let's go more holistic than that. Instead of a pill that maybe a woman doesn't want. I didn't want the pill.
Yeah.
I wanted to excel at my hockey training career.
Yeah.
And I didn't know what hormones were going to do for my muscle building and my potential and eventually my sex drive after being on it for so long.
Totally.
And so it's like that's not, I don't think, these are considerations that when my girls are this age and they're having, if they end up having any painful, periods, this is the conversation. The conversation isn't like, just take some Tylenol and put a heating pack on it. The conversation is, okay, let's get you breathing. Let's get the blood flow moving. Let's get your organs opened up. Let's get your pelvic floor opened up. Let's optimize your core, which should be optimized anyways. But like, let's optimize your body. And sure, if you want birth control, get birth control. But like, I would rather like teach my children, like, let's get your body working for you. And when we're taught that like everybody just has these painful cramps, like it's a conditioning that's like, first off, just suck it up. And women are really fucking strong. So like, I've talked about this on the podcast before, but like, if you have pain as a woman, like it starts young, and like you're taught to like just, you don't talk about it. And so even women that come in here, when we see them and you treat them too, it's like in their 30s, in their 40s, in their 50s. These women are having children. Like humans are coming out of them. And they don't even call it pain. Sure, maybe childbirth is painful, or, for some. But like we could have someone that's like severely limping and they're like, yeah, it's my back that's bothering me. But when you ask them if they have pain, they're like, no, I don't have pain. No. And you're like, wait, what? Yeah. And it's because like you just are so used to being like, you just deal. Like there is just a dealing aspect of life that women do. And so I don't know how we got started with this. This was from periods. But so that like starts, the training though starts at such a young age. And so when we're telling young girls that like, oh yeah, this is cramping, that's normal. No, that's not. That's our first sign. Like, let's get you opening up your pelvic area, And so back to your story of like, okay, how does this get better? How do we start to diagnose this earlier? It's getting that detailed history. And so if we have someone come in, we are getting a detailed history. We're asking them about their cycle. Do they have pain with their cycle? Do they have heavy bleeding? A lot of times physicians, when they go to the pill, especially if they've already are done having kids, if you're having heavy bleeding, the next thing is going to be, okay, let's do a uterine ablation. That's where you burn out the inside of the uterus. All right. F that. I don't want that. No. And then again, we're not dealing with the issue. So, I mean, this puts me on a total tangent, but this is why we end up having, women that have, like, never got their cores back after childbirth. But like they didn't realize that the scar tissue was a problem from childbirth, and then the need for the uterine ablation was a problem, and then we decide, okay, the uterine ablation doesn't work, let's take let's give them a hysterectomy, and then we're like, oh, that prolapsed, and now they need a prolapse surgery. So the soliloquy of all of this is very long, and I know I'm like kind of tangenting, but I think it's really important to know that this decision causes this decision, which causes this decision. Yet if we just took a detailed history and approached this from a different angle of saying, okay, Bella, you're 11. What if we, like, your period shouldn't be painful. Let's start here. What if we opened up that tissue when you were 11 and things started to move a lot better? Would we have prevented more endo lesions? Who knows? That we'll never know. But because you had more blood flow and more dynamic tissue is why I'm saying that. But, at least we wouldn't have put you in so much pain, right? And so it kind of just, it's all about putting the pieces together. And that's what we do. Like, we don't have a microscope. We can't look inside of your body, but we can feel inside your body, and our hands are extremely powerful. And we can visualize so much from our hands, and melding what we feel, what we find on our exams with your history. And that's the magic. And yeah, I mean, now in this day and age, physical therapy is, like, we're in a very specialized practice. We're allowed
Absolutely.
to sit and listen to our clients, and there's no time clicker from any insurance company dictating anything that we can do. But in most insurance-based practices, there's no time to get that history, even as a physical therapist, unfortunately. And even once you get it, like, there's only so much treatment you can do, and if you're not progressing within, sometimes 3 visits or 6 visits, you're done. You can't continue. And when you have clients with endometriosis and they've had it for years and years and years, or they have it, this takes a lot longer than 6 visits.
Totally.
And then we're talking about managing this throughout your cycle, and that's a monthly situation, right?
Yeah.
So anyways, that would be the gold standard. I think it's like what you had from that. It's too bad that came at such a late phase in your journey, because I think if it came earlier, things would have been identified.
Absolutely.
But man, your physical therapist must have been amazing.
She really was.
And,
oh my gosh.
I love absolutely hearing that story.
Absolutely.
So that's my answer to your question.
Thank you.
And we would try to manage the symptoms of the endometriosis, and if we couldn't do that, or the patient wanted to, pursue more aggressive measures, or if the infertility continued and our regenerative tools and our fertility protocols didn't work, then we would go down the route of sending them to a very skilled surgeon.
Absolutely.
And we definitely have referral sources for that. I'm blanking on the name of Dr. Mossbagger's practice over on the peninsula. You know the name of it?
Pacific Northwest.
Yeah, Pacific Northwest. And
Endometriosis Center?
I think it is.
Okay.
I think that's what I wanted to say.
Absolutely.
But we can link it to
Yes.
the chart here. Like,
Absolutely.
she is my go-to. I know there are other good surgeons around, but it takes someone who's been skilled and trained by people with the right eye to find the endometrial adhesions and like truly resect them and get everything.
Yeah.
And when I've seen Dr. Mossberger is so amazing. She's like showing us replays of her surgeries, and you're like, how did you see that? Like,
Totally.
I mean, I know she looks at this stuff every day, but it's just like, no wonder. That's why I'm just saying it's like any surgeon, like, first off, like, amazing to them for even going down the route of,
Not paying
treating,
well, just
treating endo, but it truly, like, it's just, and that's why it's not surprising when you see that it can be missed, and it just really can, and that's where I think it just takes such a skilled provider. And so that's what we do, is we just make sure that they're in good hands.
Totally.
And that they're with a surgeon that has a good track record or has been trained by a superstar to manage this, because the worst thing you can do for someone with endo is to go in and have a laparoscopic surgery and be told it's not endo, and they have freaking endo.
Absolutely. I think that the best thing that I did for myself is talking to 5 different surgeons and interviewing 5 different surgeons. I went to 5 different appointments, and there's a list of questions that you're supposed to ask different surgeons, like excision versus ablation, and you really have to do your due diligence, because there is people who specialize in it, and then there's a general OBGYN who also can perform surgery, and the level of training specific to endometriosis is incredibly different between these 2 different subspecialties. And so, I mean, I was very fortunate to find an amazing surgeon, and absolutely just a huge game changer for me.
Okay, so there's 5 different questions. I haven't heard this, so will you share?
Or not 5, but there's
a list
a
of
list
questions?
of different questions.
Okay, so you said one thing to ask is ask this.
Absolutely.
Yeah,
So
tell us.
excision versus ablation
Okay.
surgery. So a lot of times people will say that they're going to ablate, which is basically burn off any little lesions. They're called gunpowder lesions because they look like little cigarette burns. And so sometimes people will just choose to burn that off instead of actually, cutting it off, because what we know is that endometriosis also grows down and it's not just on the surface. And so you want someone who's going to be able to fully excise it and just remove the whole thing.
Yeah. Okay, so excise means extracting the tissue. So extracting the endometrial lesion. And when she says they look like cigarette burns, a lot of endo tissue looks like black tissue when you're visualizing it. But why it's so tricky is that it can be white. It can be a neutral color. And so that's why you have to be skilled. But a lot of endo, especially if you look it up online, looks like it's shown as black tissue. And so you want to excise it and not burn it out.
Absolutely.
Okay, so great.
Yeah,
that's
so
awesome.
you actually perfectly transitioned to my next question that I personally was gonna ask, and I think the list of questions is different for everyone, but this was what was important to me. So since I was a younger patient, a lot of times in teens, you actually don't see that type of black tissue. It takes kind of years for that to happen. So I knew this because I'd done so much research that I shouldn't have had to do, but I still obviously fell onto me when I was still like a kid, which is crazy. But oftentimes there's clear lesions, there's like pinkish lesions. And so my other question was, how often do you see those? And that's a little bit of a kind of sneaky question, because if they're like, I never see those, okay, the likelihood that they're not in the patient. So kind of just getting a gauge for how often are you finding this. And that's not a dig at people who don't find this, and in older patient populations it's less likely to be there, but just kind of gauging, yeah, absolutely.
Super good question.
Yeah.
I just thought of something, and then I want to go to if you have any other questions that our listeners should ask. But I just thought of a question. I just thought of an idea. If you end up having to do like a research project on, and you can thread it into endo at all, and you're like, I want to research it from a realm of like manual therapy and radio pressure shockwave and EMTT, like, will you just like think of how to design something in your future? Because like during in PT school you might have to do this, or even in your senior year, I think I had to do a research study. And if there's any way that we could support getting you data, and like you as the primary researcher, but you could use our clinic, like please do it. I wish I had the brain capacity to put together studies and like do my own research. And we do clinical like we track our outcomes, especially like our birth outcomes. We don't track fertility outcomes, which we absolutely need to start doing. We should definitely. I don't know why we're not doing that. Maybe Dr. Katrina is, but okay, next step meeting.
Absolutely.
No. Actually, can I give that to you to own?
Yeah.
Get us tracking our fertility outcomes. Okay, great, thank you. And then, but designing some studies. Absolutely. I think that would be cool, and especially if it was something that we could execute and give you data. Like. It would be short term, for whenever you're in school, but just keep that in the back of your mind.
Okay, I will, thank you.
Yes.
Absolutely.
Okay, back to your questions.
Yeah, and then I asked kind of like robot assisted versus just kind of general laparoscopic. So a lot of times when people do robot assisted surgery, there's a greater level of precision. There's pretty similar outcomes, though it's kind of just a personal preference, I guess.
Interesting.
How long the average surgery is for people. So some people have like 30-minute surgery averages. And what that kind of tells me is that they kind of like take a quick glance around, and really you need to be like looking under the uterosacral ligaments. Like you need to really be looking everywhere. Absolutely.
Okay, I'm going to go more a little bit on that. And what I've seen from certain clients as well is like, if someone has had, if someone's symptom, this is where a surgeon needs to take a detailed initial intake, is if you're going and your symptom is this heavy cramping, okay, I need to be looking all along the abdominal wall.
Absolutely.
I need to be looking inside the pelvic floor. That's invasive.
Absolutely.
You're moving a lot of tissue. If your symptom was right-sided hip pain, you need to be getting into that hip. You have to be moving away everything that is blocking your vision from that hip and going into that hip. And that's where it's like, I think you make a good point, and I haven't really thought about this before, so I appreciate you bringing this to my attention, is you don't really want a minimally invasive surgery.
No! You are taking 6 weeks off of work you are taking the time away from your family to heal. Like, I want you to be, like, really, like, finding it. Absolutely. And I didn't want it. Obviously, when we look into it, it's a much better and kinder on your body to have the shortest, most effective surgery possible, but that doesn't mean the shortest surgery possible. So absolutely, I really wanted someone to, like, make sure they were checking everything.
Yeah.
Absolutely.
Yeah. Okay, great. Thank you for sharing that. Any other question that you feel like was really important for you to ask your surgeon that our listeners would benefit from?
Yeah. I asked personally about peritoneal stripping, which is a technique in which they'll kind of scrape off the layer of the peritoneum. That's not something I personally wanted because of the longer recovery time in my age. Some people really want it. It was kind of just more of a personal decision. So I just encourage people to kind of do a little research into it and see if that's something that they want. I think it was coined by Dr. Redwine, and he's an amazing endometriosis surgeon, but there's just different types of excision surgery, and I just didn't really want that personally.
Interesting. I haven't heard of that either. So peritoneal stripping is where you take the entirety of the peritoneum and you scrape a lining off of it, of the entire peritoneum. Okay, so peritoneum is the fascia it is a continuation into endopelvic fascia, but it also encompasses the fascia that is around the colon, the small intestines, the stomach. I mean, that's intense. That's intense. Yeah. So I would be the same way. Like, let's research it. And maybe if you had higher up adhesions, it would absolutely be more indicated for that kind of patient. I'm sure there's indications.
There are people out there who this is the right decision for, and I'm not one of those people. So I'm not saying don't go to a surgeon that does this. Yeah. I'm saying just look into yourself and see, am I someone who wants this or doesn't want that? My answer was no. That doesn't mean anything for anyone else's answer. Yeah. I think it kind of wasn't something that I felt at my age I wanted. Yeah. Or like progression of disease, but absolutely for a lot of people they want that.
Yeah, and it could definitely be right for the right person.
Absolutely.
And that's why nothing we're talking about here is prescriptive. We're just trying to give you a look into what it's like to live with endometriosis, especially from a kid that started at 11, and maybe your endometrial adhesions started before then too.
Probably.
So, so I just think, don't take any of this as prescriptive, but take this as knowing what's out there and how this can help your life, right? Yeah. So I appreciate you saying that.
Absolutely.
That's an important factor. Great.
Yeah. That was kind of my main things that I was looking for.
All right, cool.
And it did take 5 different people until I find,
the right surgeon. Wow. How do you mind sharing how old you were?
I was 17 when I started looking, and then I found the surgeon that I wanted to see when I was 18. And a lot of it is by word of mouth in the community. So just talking to different people who had positive or negative outcomes with their surgeon. Absolutely.
Wow. Do you want to share your surgeon's name, or you don't have to?
Yeah, I saw Dr. Marissa Dahlman. She was amazing. She's at Virginia Mason. Okay. Just incredibly compassionate care. And
is she still there?
Yeah.
Oh my gosh.
She's so amazing.
I love that.
Absolutely.
Okay, cool.
I've been pain-free. I had a Allen Masters window, which is a hole in the peritoneal lining. Okay. And she was able to excise that, which is why I was so happy that I saw 5 different people before finding her. Yeah. Because that requires deep excision. So that's kind of like a pocket in the lining of your fascia, kind of. Yeah. And a lot of times people would just stitch that back up, but she actually cut around that and took the whole thing out. And it was just, I felt so fortunate that I had chosen her. Yeah. That she was equipped to deal with this. Yeah. And that wasn't even something that I had thought to ask when I was looking at surgeons.
How would you know? You're not trained in surgery.
Totally. But just that I had asked enough questions that she made the decision that I wanted. Yeah. Absolutely.
So you can see how Bella has advocated and followed her intuition in her personal life, and you can see why she would be such an amazing employee, right? Because it is just the level of questions, and having some people I think in life are just scared to ask questions, and that goes back to whether we were ever allowed to, right? Go back to our history, the confidence we have in which we ask questions, and I think like, wow, special. Thank you.
You totally get to be picky with your surgeon.
Yeah.
I think that's the best thing that you can really, one of the best things you can really do for yourself is tell, people don't get to just perform surgery on you unless you really, really like them.
Yeah.
Absolutely.
Yeah, it's incredible.
Yeah.
My question for you is, since working here, have you been doing abdominal shockwave?
I have.
Good. Okay.
Yes.
And then what about, have you tried some EMTT on yourself?
Yes.
On uterus and like kind of abdominal area? Lovely.
Yes,
okay.
Absolutely. The shockwave.
Yeah.
Definitely I can feel where I have adhesions, especially from after surgery.
Okay.
So I make sure to hit those.
Yeah.
And the EMTT actually has been super helpful for me with like endobelly bloating and that type of stuff, which has been amazing. Yeah.
Thank you. Amazing. I'm so happy to hear you say that. And then a little bit about, you also said you've been benefiting from red light. You're like, the red light seems to really help. Okay.
Totally. Okay. That also, there's a lot of like bloating that happens with endometriosis, and the red light has been super helpful and also really great for sleep, which just kind of supports a bunch of other things.
Yeah. Got to get one for your home in UCLA.
Yeah.
Okay, final question. We can cut it or leave it, whatever you're willing to share. Have you had internal pelvic work done since you've been here?
Yeah, I have.
Okay.
Or not since I've been here, just in general.
Girl,
I know.
we got to get you on the freaking schedule.
TV on the schedule.
Yeah.
Hello.
Like, you need to look at it. I know we've been super busy, but you need to find an opening. Since starting here and starting the regenerative modalities that you've been doing, have you had a cycle?
No. So kind of touching back on the pill. I'm gonna be honest. The pill really helped me.
Good.
Absolutely.
Okay.
And the thing is, I still agree that it shouldn't be the first thing.
Yeah.
The pill really gave me my life back.
Okay.
So I take a really high dose of norethindrone, and that kind of they think it suppresses further endometrial growth.
Okay.
So when I first started the pill, I immediately stopped having this pain with exercise, and I really didn't have painful periods as much.
Good.
And that is great, and I'm also glad I had waited 4 years before, or I'm not glad that I had waited so long, but I think that it really did mask a lot of the symptoms, and so I'm glad that even though I did eventually take the pill, that I did also seek out surgery. I think when you're having this crazy type of pain, just taking the pill and just forgetting about, like, that wasn't the right option for me, I would say. Because then I found out, like, that I did have endometriosis, and that does have me make, like, different decisions about my health care. And I wanted to have that surgery to preserve, like, fertility and that type of stuff. So if I had just taken the pill and chosen to forget that there was something happening, it would have probably just gotten worse and worse. And I wouldn't have, like...
Yeah. And there's no really knowing if you took the pill first, if that would have helped. If you still had all those lesions, because you don't know if those lesions are... like, if they're the source of pain too, right? So, like, it's a chicken or the egg, right? And the pill might be the right choice for a lot of people. So, you're absolutely right, and I don't mean to bash the pill.
No.
I just think that, like, identifying the root cause of the pain is really, really important.
Absolutely.
From even like a psychological perspective,
Absolutely.
really. But also from a management perspective, because like you said, like, okay, are you going to want to have babies in 5 years? Like, that might be something that you want to be considering, right? Can I get my ovaries moving as best I can? Can I get the most movement out of my organs as I can? So these are just good considerations. I need you to experience pelvic floor therapy here and some abdominal work here because that is game-changing. The regenerative tools are absolutely amazing and hugely beneficial, and that's why I've brought them in here. And everything that we use them for in managing endo, in helping our infertility clients, everything we use them for is off-label. So it's an FDA-approved device. And it is also researched only on musculoskeletal conditions. And I've just by default, knowing what I know, I've been able to blend these tools into helping conditions that we treat. And they've been absolutely game-changing, but it's very real that it's an off-label use that I'm using it for. So.
Totally.
Yeah.
Absolutely.
Thanks for being here.
Thank you for having me.
This was epic, and I think
awesome.
a lot of people will benefit from hearing you and sharing your story. So thank you for being so vulnerable and open, and continue being you. And I cannot wait for her to work here when she graduates as a pelvic floor physical therapist.
Oh, thank you. Thank you
Yes.
so much for having me. This was really an amazing experience, and so awesome to have these answers and this conversation created around endometriosis and pelvic floor therapy.
Cheers.